Good evening to everybody. Good evening, Saqib. Can you hear me?
I can loud and clear.
Okay, good evening, Saqib, and thank you very much for doing a hat trick of sessions. They have been received very well. So it will be great today because I think you are going to concentrate basically on head and neck.
That's right.
Right. And today we have got a new faculty member, Dr. Hassan Rahman. He'll join at a particular point. He is a head and neck as well as a neuroradiologist. So, and in November, I think Dr. Hassan is going to plan a further dedicated session all by himself also. So, without losing more time, Saqib, over to you.
Thank you, Dr. Khan. I'm just going to share my screen in just a moment. Right. And we are.
So, just one second, please.
Yeah.
Candidate one, are you with us?
Good evening, sir. Yes, I am here.
Okay, thank you.
Excellent. Just double checking before we start candidate one. Can you see my screen?
I can totally see it, sir. Thank you so much.
Excellent. And you can hear me loud and clear?
Absolutely clear.
Perfect. Well, thank you so much and welcome everyone. Thank you so much for joining me again. As Dr. Khan mentioned, I'm one of the radiologists that works with this team and hopefully one of my colleagues who's actually an old medical school friend of mine, very established in the domain of neurosciences and head and neck radiology in, I believe it's Brighton Hospital. So hopefully he will be joining me shortly as well. So as with the previous sessions, this I will just go through a very quick refresh just to explain the purpose of my sessions and how we will likely go ahead and conduct them. First and foremost, your feedback really does matter to us. I please encourage, and I've really benefited a lot from the feedback. We live off your feedback. This is what feeds us as especially as consultants. So please contribute. I only know what to improve on and what I can do better and what you want if you tell me. So please, I encourage as much feedback as possible, positive or negative, either one, it will be beneficial to us. So please make sure you use the link at the end. Why is this such an important topic when I talk about managing the management? It's important in the domain of clinical radiology anyway, but more so recently in the domain of the FRCR 2B, because now all of a sudden there was always some management element to it involved, but now it's actually part of the mark scheme and criteria. So there is a specific section of the all elements from the rapid report, the short case reporting, long case reporting, and the Viva reporting, where they insist that you have to make a comment about the management. It's a huge domain in the answer that you give. So the purpose of the way I'll be conducting my sessions today are not necessarily to show you an amazing, extremely rare case that you've never seen before. Hopefully, I will contribute to your general knowledge and go through your radiological knowledge, but it's more to try and convince you and try to get an idea of how you can keep that conversation going, how you can transition from explaining what your findings are, coming to a diagnosis, and then keeping the ball rolling with what do you do next? What is the differential? What is the management? Who needs to be involved? And this is why I'm very particular on the way it's presented. What I find a lot of the time people do, they're so focused and so drawn into the actual talking element, looking at the actual findings, that they get lost in the rest of the conversation. So I'm really going to insist in all the candidates today, I want a nice, succinct, one line concluding statement of your findings. Try to avoid telling me about new findings after you've told me your summary. Just go to your summary and with that same breath, go to your differential diagnosis or your main diagnosis. And in that, again, carrying the conversation going, go straight into the management. Okay. And give me as much information as you can about the management. The idea of today is to try and help you build that knowledge, help you build that systematic approach. Okay. And again, I'll go through a quick refresher. Maybe some of you have seen it before. This was inspired by a GP colleague of mine and during the Viva type exams, there were three topics that they used to use to try and score the maximum points in management. I've altered this to make it a bit more relevant to the radiology world. You do not have to use these topics. You don't have to populate these topics. These are just hints to try and structure your thought process. So once you've seen the scan, what does the referring clinician need to do? This means, does the person need to know immediately? Are there any immediate management steps that need to be taken? Basic blood tests, any immediate treatments, steroids, antibiotics, etc., etc. The more information you tell me, the smarter you look in that domain. As the radiologist, are there specific interventions that can be done? Are there further investigations that need to be done, especially specialist investigations? And then when I say what does someone else need to do, I mean to say, is there a specialist referral required? And if so, who? Remember, even when you send these patients, whoever, whichever scan you see, it has to go to the right person. There has to be a logical reason why. So we'll hopefully go through a few tests, a few cases, and go from there. Right. So without further ado, candidate one, are you ready?
Please, sir.
So I think in the past, I think there have been problems when I've asked you to take control, not necessarily you, but when I've asked candidates to take control with the scrolling. So for the purpose of today, I think I'll control the scrolling, but you can just tell me if you want me to slow down, go faster, go north, go south, whatever you want. Is that okay?
Perfectly fine.
Great. And if there's any issues here, we'll try to figure it out. Right. So this patient presents with a headache. So a CT was done, and I'll scroll through for you.
So I've been provided with axial slices of CT brain, plain study of a relatively young patient who presents with headache. I'll first go through the images for the initial few seconds, and then I would like to describe my findings. On the initial assessment, I cannot see any obvious hydrocephalus. The high convexities appear unremarkable with no signs of obvious subarachnoid convexity, subarachnoid hemorrhage. Bilateral basal ganglia region appears unremarkable. Over here, I can see, sir, can we stop here, please? In the, I can appreciate a well-defined hyperdense round focus in the suprasellar region, just lying anteriorly to the midbrain. In my actual practice, I would like to measure this area and see this on orthogonal planes as well. Considering its sir, can I request for sagittal or coronal
This is the only
reformats?
image available.
Right. So this, I cannot see, it's a well-defined, well-demarcated, non-infiltrative lesion. It can be seen well. Sir, would you mind please scrolling a bit so that I can appreciate its margins from the midbrain? So it can clearly be seen separately from the midbrain. It's lying predominantly within the interpeduncular cisterns. Around this, I cannot appreciate any obvious perimesencephalic hemorrhage or subarachnoid hemorrhage. The temporal horns of the ventricles that is visible in this cut appear unremarkable. Otherwise, the brain is also unremarkable. So, considering a patient who presented with headache with this radiological finding, my differentials would be a suprasellar structure that is well defined, and my differential would be an aneurysm or maybe a benign suprasellar mass lesion. I would further recommend the referring physician to investigate it further with the help of MRI head with contrast to know its exact pathology. Considering that I'm also suspecting it to be an aneurysmal, angiography would also be suggested in the baseline.
Which one would you want first, the MRI or the angiogram? You can only do one.
It's a bit hyperdense relative to the rest of the brain parenchyma. I cannot see any calcification, any cystic component, or I would go for the MRI head.
Okay, fine. So we did a CT. So what does the CT show you? I'll stop right here.
Right. So
what's your final diagnosis?
So my on this CT angiography, this is purely contrast opacified, suggestive of aneurysm, suprasellar aneurysm, non-calcified, I cannot see any blood clot within it, I would immediately inform the referring physician, and I'll further guide them to consult the IR team to manage it. They might proceed it with coiling so that it to prevent it from rupturing.
Okay, excellent. Very nicely done. So exactly right. So basilar tip aneurysm. So you actually did very well there. Your description and your location, describing the anatomical. And remember, the exam is not just to obviously test your general knowledge of the different pathologies. In my exam, they were asking me a lot of pathophysiology and anatomical questions. You could say some were easy, some were hard, but they were testing anatomy as well. But if you know it and you can say it succinctly, show off your knowledge, show that you know all of the structures that run in the supracellular cistern space, what kind of structures would be affected by this aneurysm. So location, the degree of mass effect you mentioned. The only thing you have to do to develop the answer slightly further is that you can describe the morphology of the aneurysm. And the most common descriptions are saccular and fusiform. Mainly in the intracranial system, you tend to find saccular morphology at these junctions. So one of the things to bear in mind, because we sometimes potentially can over-report in the basilar tip, and you see this concept called the infundibulum. There's another name for it. Hassan, I'm not sure. Do you remember what the name they use for that slight outpouching where at the basilar tip? If you can hear me. No, you can't. There's another word I remember. I distinctly remember there's another word, but the official term for this one is called infundibulum, where it's just a junctional sort of outpouching at the basilar tip. So if you imagine this is the basilar, that is the posterior circulatory arteries. That's where you get this triangular type opacity. But this saccular aneurysm is very distinct. So that was explained quite nicely. So I think, yeah, the key thing is remember in the back of your mind, from the differential diagnosis you gave me, fairly reasonable for you to say potentially a benign supracellular mass. What's going to potentially harm this patient more, an aneurysm or the benign mass? And that's what
Aneurysm,
you
of
should
course.
exactly right. So in that situation, what's more important as an investigation from a clinical management point of view? The CT angiogram. Yeah, if it was actually the CT angiogram showed that this was a possible heterogeneous enhancing type mass, yeah, you can always do an MRI head afterwards. But the key question is this an aneurysm which we need to try and organize urgent treatment for, or can we leave this alone? So the management is fairly simple here. I know you mentioned about the neurovascular IR, but remember, the neurovascular IR team, they accept referrals from different teams. So it has to be under the parent specialty. And the parent specialty in this case is the neurosurgical team. Then the neurosurgical team will then obviously discuss. So when I mean send it to the right specialty, sending it to a neurovascular IR is not the wrong answer, but it's also not the exact answer we're looking for. The neurosurgical team plus or minus embolization through the neuro IR is probably the more complete version. Does that make
Right,
sense?
sir. Totally, sir. Thank you so much.
Excellent. Right, let's carry on. So, next case. This patient had a mass in the neck. A scan was performed. What kind of scan is it? Question number one.
So this is system EP scan that is ideally done for location of ectopic parathyroid gland.
Okay, carry on. What do you see?
So in the initial images, I can appreciate there's uptake of there's radiotracer uptake in bilateral thyroid lobes fairly symmetrically. There is mild lack of uptake on the left side and close to the inferior pole. In the lower images, I could appreciate some uptake in the on the left side superiorly. I cannot appreciate any. There is normal radiotracer uptake in the salivary glands. I cannot appreciate any abnormal ectopic midline radiotracer uptake centrally. So probably there is some pathology at the low, close to the
What do you
lower
think of
pole of.
this?
So this is the subtracted images showing that there is fairly increased radiotracer uptake at the upper pole, close to the upper pole of left on the left side. I think so. So
gone blank.
I'll investigate this area further with.
Oh, give me a second. I can't hear you anymore.
Are you
Oh,
able
yeah,
to
I can
hear
hear
me
you now.
now, sir?
Yeah, that's fine. I can hear you now. Go ahead.
Yeah. So in these subtracted images, I can appreciate the radiotracer has been washed off from rest of the thyroid gland, while there is persistent uptake close to the upper pole on the left side. I would correlate my findings with. I'll discuss this finding with the referring physician, and I would advise to correlate this with targeted ultrasound. I would also request them to go ahead with serum parathyroid hormone and serum calcium levels to check for the parathyroid hormone levels, and to evaluate for if there is an hyperparathyroidism. I would also advise them to check for rest of the manifestations of hyperparathyroidism, like for the hands, to look for the skeletal manifestation or
Okay, good. Keep going. Keep going.
yeah.
One more, two more points. Keep going. See if
Since
there's anything else you want to.
hyperparathyroidism also makes a part of the MEN syndrome, I would also suggest them to screen the patient for MEN 2A and 2B.
What kind of? Is it a parathyroid adenoma that men causes?
MEN 2A is basically parathyroid hyperplasia.
Okay,
I'm mixing them up. I'm sorry, but I guess it's
that's okay.
hyperplasia.
Right. That's all right. Right, fine. So, follow-up questions. Why do they give pertechnetate and systemibi?
So basically, they are taken up both by the thyroid and parathyroid, but system AB is retained by the parathyroid only, while
Why don't they
pertechnetate
just
washes
do
off
the
later.
why do they just not do the systemibi scan then? Why do they give the pertechnetate in this situation then? Why don't they just give the systemibi?
Uh, Sorry, sir, not sure.
So you're nearly there. The idea is that protectate is exclusively in the thyroid gland. In when it comes to negative, it's taken up in lots of places in the body, but protectate is exclusively in the thyroid. Systemibi is in the parathyroid and the thyroid. So essentially, it's that
Oh,
subtraction image that
oh,
shows
yeah,
where whatever you don't see from the protectate scan, that's what's left over, and that's what tells you where the adenoma is.
right.
Excellent. So the key thing really is, and you actually described it very nicely. Why do we screen the entire, although we're looking at the neck, why do we look at the entire chest?
For the ectopic parathyroid
Exactly
location.
right. And you got that exactly right. So very nicely done. So the number of nodules is important. Trying to figure out if there are ectopic nodules, especially in the mediastinum, anywhere else. Sometimes it can go towards the salivary glands, base of the neck. So that's very nicely explained. So your management was brilliant here. There was a couple of things to let you know about. So first of all, the PTH calcium levels, excellent. The clinical syndromes, etc., very nicely done. So the management has changed. They routinely do 4D CT now, multiple contrast enhanced CT, so they can really accurately localize the tumor from an anatomical perspective when they do surgical procedures. We're moving on to an era of minimally invasive surgeries. So the more information they can get before the procedure, the less chance it is that they can actually preserve thyroid tissue and only remove the actual adenectomy. Or alternatively, if they are concerned and there's lots of localized tracer uptake in multiple areas, F18 choline PET is also another option. This is taken up by parathyroid adenomas. So that is another way of localizing, especially ectopic parathyroid adenomas. But the key thing is, remember, I think the only thing you didn't mention to me is who needs to see this patient next. And the answer is the endocrinology team. And usually there's difference. So they call themselves a sort of gland surgeons, or then they can do adrenal surgery, neck surgery. But head and neck surgical team is a reasonably safe option here. Make sense?
Totally, sir. Thank you so much. So, sir,
Excellent.
from the system AB scan, our next advice should be for 4D CT and F18 cooling PET.
F18 choline PET is only a trouble-solving tool.
Oh,
4D
okay.
CT is usually part of the management, and it really picks up to see if it's an active hormone-producing parathyroid gland. So the usual order of events is ultrasound, 4D CT plus or minus system maybe scan, and they do the others. But normally the functional adenomas are picked up by the system movie scan. It's the simplest, cheapest option. Choline PET is only used for these sort of difficult, tricky cases.
All right. Thank you so much.
Perfect. Okay, next case. You probably saw that. Never mind. I scrolled too fast. 1 second. But anyway.
I'll be true. I didn't see the diagnosis, honestly.
Okay, fine. So give me a second. Let me just get the image up. Right, go ahead. So this patient presents with a pain and swelling in the neck. I'll scroll through these images for you whenever you're ready.
Yes, sir. Please. Thank you. So I have been provided with multiplanar, multi-sequential fat suppressed sequences of a relatively young patient who has swellings, who has a history of swellings in the neck. I'll take my time to look through the images and then I'll start presenting my finding. In my initial view, I can appreciate an altered signal intensity area close to the right carotid sheath. It is fairly well defined and I can appreciate both internal and external carotid arteries being splayed by this mass lesion. It also appears to have multiple internal flow voids. I would like to check its clear relationship with the carotid bulb and whether it is lying close to that or not. The flow voids of the from the base to skull, it appears to arise close to the region of the carotid bulb. The flow voids of the internal and external carotid artery as well as internal jugular vein that is lying close to it are fairly well maintained. I would also like to appreciate. I would also like to see this pathology on the other core sequences as well, if available. And also including the post contrast T1 fat set.
Okay, here's the post contrast sequence for you.
So in my in the post contrast fat set sequence, I can appreciate the lesion described is avidly enhancing. A similar configuration, similarly enhancing lesion but of smaller size is also appreciated on the contralateral side, and it also appears to be of the same pathological origin. Rest of the parts of the neck, including the parotid, submandibular glands, sternocleidomastoids, and posterior neck, grossly appear normal. So, coming to the these are two bilateral variable-sized neck masses, predominantly arising from the carotid sheaths, with and are avidly enhancing. My differentials would be carotid sheath tumors versus schwannomas. However, I cannot appreciate the typical salt and pepper appearance of the nerve sheath tumor in this. So carotid body tumor would be of my will be my primary differential. I would inform the referring physician and advise them to take head and neck surgery take head and neck surgical consult for these tumors. I would also ask them to go ahead with MIBG scan for further assessment. Yeah.
Okay, excellent. Very nicely done. Quite a very succinct answer there. Exactly right. Carotid body tumors, bilateral. Remember one thing, and this is sort of advice I'd give for anyone and everyone reporting radiology as a rule of thumb, because remember, to an extent, there was a slight moment where I thought you may not have got the second one, and you're not the first person to have made that mistake. A lot of people are so focused on the one, they forget the other. As a rule, where there's one, there's two. Just have that in mind. Where you see one met, there's a second met. Look even closer. Where you see one bone lesion, there's a second bone lesion. Just prompts you in the back of your mind as a force of habit to look for the same thing on the other side. Look for a multiplicity of the lesions itself. Okay? Where there's one, there's two. Where there's two, there's three. So keep looking the more you find. And that sort of helps you get out of that tunnel vision mode. So very nicely picked up. But exactly right, your description was very nice. Your relationship. So some of the buzzwords, remember. So there's certain conditions, although this is sort of fairly nice, common case that we've got, or like a well-known case. But they talk about the salt and pepper type opacities there as well. But you have to talk about the relationship, like things like splaying of the carotid vessels, things like that. I don't think I've heard you saying it, but that's another buzzword that they commonly use in these kind of situations. So let me just quickly go
Right.
back to my initial slides. Um, so exactly right. So the key thing is, remember, you sort of touched on the idea that we might need to do some kind of a nuclear medicine scan, like MIBG scan. Remember, go back to your basics in this situation. So catecholamine in excess, if there is a functional type tumor, cranial nerves. So these patients, especially if it's a large mass, you need to make sure that they perform a cranial nerve examination because that might warrant slightly more urgent treatment. So would you biopsy this?
Never.
Why?
It can. It's these are highly vascular, so they can lead to a catastrophic bleed.
Absolutely. Perfect. Embolize?
Yes,
Who does it?
pre-surgically.
Yeah. So,
Pre-surgically, so that on table they can encounter less of a bleed.
right. So, our colleague Dr. Hassan Rahman will tell us otherwise. Do we embolize these or do we leave them alone and straight to surgery?
We tend to follow these up depending upon how big they are and what clinical symptoms the patient is having. Can you hear me, by the way? I have
Yeah.
unmuted.
Loud and clear.
Okay. And the other um, thing you guys mentioned previously, you were talking about biopsying them. You're right, we shouldn't biopsy them, but people have biopsied them in
Yeah.
the past. And it doesn't necessarily mean that person is going to, just bleed all over the place. This does happen surprisingly commonly. But yeah, if you can avoid it, you should avoid it. Always get an MR, always make sure that you have the classic features. And depending on the size, then we decide whether we want to follow these up with like 6 monthly to yearly follow up, or whether the surgeons want to remove this depending on the size and the clinical symptoms.
Yeah, absolutely right. So the other thing is, bear in mind, a lot of the time is that there are also complex head and neck surgeons who take these on, but quite commonly you find that the vascular surgical team are involved in this, especially if they're working very close to the carotid artery. It's a large tumor, and you think there's adventitial involvement, and they may need to do a graft or a bypass. The vascular surgical team need to be involved. But remember, with any of these kind of tumors, this is where you can sort of open up the conversation, especially if it's bilateral. You're thinking of some kind of phacomatous, a syndromic type case. So it's worth mentioning these kind of trials. I can never remember I think this was pulmonary chondromas and something else. I can't remember what else it was, but it's worth looking into these sort of syndrome, these kind of places.
Right.
But yeah, so the other thing, just again, I'm not sure if people are using these kind of classifications. Every pathology pretty much has some degree of grading and classification. The only one I've come across is shambling ones, and it just gives you an idea of the rough extent and size of the tumors themselves. And it gives you an idea of how likely it is that it's going to be associated with symptoms and how aggressively they need to be treated. Okay, nicely
Right.
done.
Right.
So we're going to move on to the next case. So this patient presents with, okay, before I show you the next case, the next patient is a young child, presents with worsening swelling on the eye. The A&E team or the emergency department team have asked for some imaging. What kind of imaging would you recommend?
May I know the age of the patient, please,
A
sir?
12-year-old, pain, fever, and swelling, cannot open the right eye.
So ideally, it should be by MRI, so that we can present the baby from the 12-year-old patient from the radiations of CT.
Okay, well, it's 2 o'clock in the morning.
Okay, and then we can, if if there is somebody in the department for ultrasound, then of course ultrasound. Even if ultrasound is not available to evaluate for the swelling, then of course we are left with the only option of CT.
What kind of CT?
There's swelling on the right side of the on the right orbit, right? Preceptor swelling.
Yep. What kind of scan then?
CT head, including the orbital area. But that should be the last priority, considering considering the amount of radiations. Or we might wait till morning if the physician thinks that it won't be that much critical.
Okay, so here's the scan. So I'll give you the axial slices, and in your own time, if you could go through these.
So I've been provided with contrast-enhanced images of CT of a young 12-year-old boy who has presented with right eye swelling. I'll take my time to review the areas, and then I'll start presenting my findings. In my first glance, I could appreciate their fluid levels in the right maxillary sinus. I could appreciate air density areas in the right intraorbital region. May I please know if the patient has history of trauma? I could see some fractures involving the lateral orbital wall and
No
also
trauma.
sorry?
No trauma.
I could appreciate some cortical discontinuity in the lateral orbital wall and also the multiple walls of the right maxillary sinus. In my actual practice, I would look at the reconstructed images and bone windows and also look for the density of the maxillary sinus fluid. I could also appreciate the preseptal swelling on the right side. The right ethmoid air cells are also partially opacified. So can I see the coronal or bone window for this patient if possible?
No bone windows. I'll show you the coronals.
Oh.
Okay. What do you think is going on now?
So there is air density area, of course, renoted in the coronal sequence as well.
What about this slice here? What do you think about the medial wall here?
It is disrupted. No.
Anything more aside from the disruption? And remember, use your symmetry. Compare it to the other side.
Yeah.
What about the globe itself?
Yes, I would like to. Can you, sir, please scroll once more so that I can compare both sides? I could appreciate there's a bit of proptosis if that's not positional. The optic nerve, the muscles, they're unremarkable. I could not appreciate any significant fats running within the retroorbital area.
Okay, summarize your findings.
So there's preorbital, I could appreciate right-sided preorbital swelling and inflammatory changes along with fluid in the right maxillary sinus. I would like to know the history of the patient. Is the patient is having fever?
Fever, pain, swelling, and eyelid
So
shut.
can it be a complicated right maxillary sinusitis leading to I would like to see the post-contrast images as well to rule out any venous obstruction leading venous thrombosis secondary to the maxillary sinus infection.
What kind of scan is this?
Oh yeah, this is a post-contrast. I'm sorry.
Okay, fine. Well done. So yeah, so slightly more tricky scan. So a lot of the number of times I've had this referred to me when I've been on call, and the number of times actually ever come back positive is one. And of the last maybe 9 to 10 years I've been doing this. So this is orbital cellulitis. Now, what do they mean? But have you ever heard the word preseptal and postseptal?
Sir.
Have you ever heard of that?
Sir, yes, sir. So
what does that mean, and why is it significant?
I'm not sure about the significance, but this patient had preseptal, all the inflammation and signs of cellulitis here.
So in this case, yeah, you're right. There is actually disruption of the maxillary sinus wall, but that doesn't necessarily mean it's from a fracture. Can you see over here? There's a collection, and it's an enhancing wall. And plus, there is gas within the orbit as well. So there is clearly destruction and some kind of a process causing a disruption of that medial orbital wall. But it's actually from aggressive sinusitis that's eroded through. So this is orbital cellulitis, and it's a lot more dangerous and more aggressively managed. This is essentially the equivalent of a medical emergency, which is why whenever these patients present, no matter what time of the day, the first thing you do, even if it's a younger patient or if it's a 5-year-old, but the concern is an orbital cellulitis, you do CT imaging ideally, because that's the fastest. It gives you the information you're looking for, which is what part is involved, are there any collections, and are there any secondary complications, such as extents? Does it go into the brain parenchyma? Is there a dural collection involved? And it really distinguishes, is it preceptal? So remember, the etiology of the two are very different. The preceptal ones are typically caused by lymphatic drainage from, for example, gum disease, can be orbital cellulitis, periorbital cellulitis, whereas the orbital cellulitis typically happen from a fairly aggressive type of infection from the sinuses directly adjacent to orbital wall. They're typically managed a lot more aggressively as well. So I'll go through my slides very quickly. So the septum you don't really necessarily see. I'm sure you can, the specialist can see it quite clearly. It's this very thin fascial margin. You can see it slightly clearer on MRIs, but it's just really a distinction of where the infection is based. Is it anterior to this line or posterior to this line? Anterior, we call it periorbital cellulitis, and it can be managed conservatively. Orbital cellulitis, a lot more people need to be involved in the discussion. And that's why the distinction between preseptal and postseptal is always there. Collections and subperiorbital abscess, which is exactly what we saw in this case, the proptosis, ophthalmic vein, and you sort of did touch on this, wherever there's an infection, or inflammatory process, the adjacent veins are much higher chance of thrombosing. So it's good that you mentioned that. Intracranial spread, what I mean by this is there any sort of meningitis type involvement? Because that's what can progress with these kind of patients. So very urgent finding, needs urgent antibiotics. I mentioned MRI, but it's not really necessarily something that needs to be done for this patient, but they need prompt ophthalmology referral. Leave this alone and this patient can lose their vision, especially if it's a young child. Make sense?
Totally, sir. Thank you so much.
Excellent. Right.
Can I just add a couple of things to this? Is that okay,
Yeah,
sir?
of course.
Saqib, I mean, he has hit on that point, but I just want to hit home again. When you have a child coming in and the clinical team is raising the alarm bells, screwing orbital cellulitis, think about what is urgently required. An MRI takes time, it takes ages, you need to prep it. Sometimes you can't keep the child still, you need to call in an anesthetist to calm the child. All of that takes time. When an emergency like this, always think, what is the quickest way to get the necessary imaging in because as Saqib said, the patient could lose their vision. And sinusitis leading to cellulitis is a very common pathology that you should be aware of, especially in kids. So that's all I wanted to add. He has really covered most of the things that needed to be there, but always think about, if it's an emergency, what is the quickest way to get the modalities the patient get the management they need before they suffer some catastrophic injury as a result?
Right, so thank you so much.
Right, so we're going to do one last case. I'm just going to quickly load it up first. Right, can you see my screen?
Yes, sir.
What can you see on the screen?
MRI?
Yeah,
T1.
perfect. Right. So I'm just going to scroll through and tell me what you think. This is the only sequence available. Patient presents with worsening headache and vague neurological symptoms.
So this post-contrast axial T1 images shows extensive leptomeningeal enhancement with dilatation of ventricles concerning for infective hydrocephalus. The leptomeningeal enhancement and pachymeningeal enhancement is smooth, relatively non-nodular. So I'll look for the sinuses and mastoids as well on T2 to look for any etiology leading to this aggressive infection. Since it's it's smooth and non-nodular, the possibility of it being neoplastic involvement of the meninges is down my list of the differentials. And I would also like to check for check if there is any prior imaging done for this patient. I would like to probe for the cause of this leptomeningeal enhancement, whether it's infective or neoplastic. I'll call the referring physician and convey my findings to this as it is emergency. Patient is having hydrocephalus. I would also look at the coronal and sagittal sequences to rule out any herniation, though there is no midline shift noted on this study. but still, since it's hydrocephalus is developing, the patient needs an urgent relief of the obstruction. I would like to screen the patient for the spine as well to look for any meningeal enhancement over there in the cervicodorsal or lumbar spine.
Okay, that's fine. I think that you've covered quite a lot there, actually. Very nicely done. So you got it immediately. A lot of the people I've shown this to, they're sort of umming and ahhing because it's a post-contrast scan and it's not something they report frequently. You sort of lose track of the simpler things. And this one, yeah, you're exactly right. So you can see lots of this enhancement directly around the sulci. There is some dilatation of these sulcal spaces. But you can see it's only really the sylvian fissure, the ventricles, the rest of the sulci are actually slightly normal looking, right? But yeah, all of this is just enhancing leptomeninges. So the differential list you gave me was quite good, actually. So, the Chapman book really gives you a really nice page. I tried to get an image of it, but I couldn't find a digital version of it. So I couldn't get it back in time. But if you look in your Chapman books, and it distinctly describes leptomeningeal enhancement, and there's like 4 or 5 really key diagnoses. And the key ones you think you can actually be a normal finding following a lumbar puncture, which is another thing that you need to mention in management. If you're especially saying that this could be an infective process, a lumbar puncture is really going to be a main diagnosis.
Excuse me.
So yeah, so you
I'm
clinically say again.
I'm sorry to interrupt you in between. I had this thing in my mind, but then presence of hydrocephalus, I thought that in hydrocephalus, should we be doing that or we can
So, I
recommend
mean,
that?
the question really is also, is that true hydrocephalus? Or is that
Right.
just essentially normal looking ventricles in an older person?
Oh,
Yeah.
but
So
this
I know
entire
you sort of mentioned that there was sort of dilatation, but the temporal horns were actually normal looking. And then you've got to think, where is it all communicating? But meningitis, you do these things all the time. And a
right.
lot of these patients, yeah, they do have, especially if they have pus in the ventricular system, you still need to do a spinal tap at some point to confirm the diagnosis.
Right.
If it's really significant pyogenic ventriculitis, they're the ones that need neurosurgical management, direct drain into the ventricles. But this really isn't on that spectrum. You would have seen some kind of debris or more enhancement of the ventricular system in that case. So in this one, really, it's an urgent finding, as you mentioned. Check for signs of infection. Meningitis is the one that you're most worried about. If this is malignancy, sarcoid, a normal variant following a lumbar puncture previously, these are not things someone's going to die from. What they will die from or have significant issues from is meningitis. So that's the first thing you need to rule out. So that's why you need to sign point for an infective process. Whole spinal right, very good, valid point, especially if you can't find a clear cause. You can look to see how far it spreads, if there's another lesion elsewhere, especially if you have tumor seeding. Do the neurosurgical team need to be involved?
Sorry.
Do the neurosurgical team need to be involved?
Yes, sir. I guess because if at some point the hydrocephalus, if there is hydrocephalus and it progresses,
Let's
they
say
need
there's
to
no
handle.
hydrocephalus.
So not for the time being then, because infection would be managed by the neurology team.
Absolutely right. So yeah, this is an important distinction here. The reason I mention that as a question mark is we find a lot of people say brain must be neurosurgeons, heart must be cardiology, cardiothoracic surgeons. So it's not always as straightforward as that. You have to, this way you have to have some kind of a thought process of why you're sending it to a certain person. So yeah, you're right. If the diagnosis is going down the route of an infective etiology, it does not need a surgeon's input at this stage. Neurosurgical teams are only really involved if they are planning on doing some kind of operative management for these kind of patients. Otherwise, the neurologists do a good job, the acute medics do a good job in these kind of situations. Okay,
Right,
perfect.
sir.
Right. Candidate 1, thank you very much. Very well done. I think
Thank
we'll
you
move
so
on
much.
to candidate 2 now.
Yes, good evening, sir.
Hi, good evening. How are you?
I'm good, sir. How are you?
Right. Good. Thank you so much. Ready to go?
Yes, sir.
Can you see my screen?
Yes, sir.
Excellent. Perfect. Right. First case for you. This patient presents with some tremors in the hand. What do you
Okay.
think?
So here I'm provided with the nuclear imaging pictures of a patient who has presented with tremors in the hand. I think this is a DAT scan in which I can see that there is a tracer activity noted in the region of basal ganglia, and however, this is looking more like a dot. So, in a normal DAT scan, it should be comma-shaped appearance. If it is a dot-like picture, so I'm suspecting, correlating with the history, the patient might have Parkinsonism. Uh, and I would convey my finding to the referring physician. And yes, and this patient will need referral to the neurologist. And I would also like to compare this with the, I'm not sure, but probably the imaging features of the patient, if any radiological imaging has been done for this patient. And yeah, and with this patient will need neurological referral.
Excellent. Very nicely done. So, are you by any chance a nuclear medicine specialist?
No, sir.
Okay, fine. So the reason so nuclear medicine is one of these things that actually catch a lot of people out. It's a fairly small branch, but it's an interesting branch of radiology. And I would highly recommend anyone before they're about to sit the exam, is you can go through the nuclear medicine theory fairly quickly. It just as a refresher, just to go through these things, because they're ignored so much in preference to CT abdomen, CT heads. You sort of forget about the nuclear medicine scans, and when they come up, it completely stumps people. And like for example, like they can ask you lots of questions. So, what is the isotope they use in that scan?
So, I'm so sorry, sir. I mean, I have no idea about it.
That's okay. So this is exactly what I mean. So it's I123 ioflupane. I wouldn't. It's one of the only reason I remember that is because that was the very first physics question I received when I did my FRCR 2-1. That's why it will forever be in the back of my mind. It was the very first question I was asked in my career as a radiologist. That's the reason I know it. But these things are very easy to forget unless you revise them. Like I said, the theory behind it is fairly quick. So you're exactly right. You described it quite nicely. You normally see that comma tail uptake. The sort of the long stem of the comma is the putamen, and the actual dot sign is normally the head of the caudate nucleus. You typically find that it's the putamen that lose activity earlier on. So this is a normal scan, what it should look like. This is the abnormal scan, which shows that it's more of a dot and slightly more so reduced uptake on the left side. So very nicely described and excellent. You use the word Parkinsonism. It's a very distinct difference because Parkinsonism is a spectrum of a disease. The underlying cause can be Parkinson's, multisystem atrophy, lots of these neurological neurodegenerative diseases, but Parkinsonism is the right diagnosis here. Nice. So, is it an urgent finding?
No, sir, it's not an urgent finding.
Right. Not everything has to be relayed to the initial clinical team urgently. Remember that in your answers. So this is where you can sort of explain clinical symptoms of Parkinson's versus other neurodegenerative diseases, neurological referral, and MRI, particularly if you're concerned that they don't really fit in with the spectrum of Parkinson's disease and you're suspecting another cause, such as Lewy body dementia, and you can actually have MRI findings in that case. So it's just to have your brain thinking of what do you do next in these kind of situations. Perfect. Right. So we'll move on to the next case. Right. Give me a second. This patient presents with severe headache. I'll scroll through the images for you.
Yes, sir.
And also right-sided weakness.
Okay, so here I'm provided with axial non-contrast images of a patient, brain of images, axial non-contrast images of brain of a patient who is presented with right-sided weakness. While scrolling through the images, I noticed that there is a hyperdense area of blood attenuation noted in the left parietal region. Sir, just a second, please. Yeah, in the left parietal region, left temporoparietal region, with some hyperdense, which is, yes, sir, which is causing compression over the ipsilateral ventricle. The significant perilesional edema causing compression over the ipsilateral ventricle with midline shift. Also, I noticed that there is a hyperdensity noted in the surrounding circle spaces. This is mainly in the region of lentiform nucleus. And in this patient, I would like to correlate this with the history of the patient. If the patient is a hypertensive patient, and it could be also, sir, can I please see the basal systems in my routine practice? Yes, I think, yes, there is also hyperdensity noted in the basal cistern, and I would like to see the ventricles also to look for any intraventricular extension. Uh, Okay, I'm not able to see on these images. I'm not able to see any intraventricular extension. So, okay, so this is hemorrhage noted in the left temporoparietal region, in the region of basal ganglia with subarachnoid hemorrhage, and with subarachnoid hemorrhage, and also the uh, extension of the bleed into the basilar
Okay.
cistern
So
with.
let's skip ahead slightly. So the clinical team they know it's an urgent finding. What do you do next?
So, if the patient is still in the gantry, I would urgently advise CT angiography to rule out any vascular malformation or aneurysm as a source of bleed.
Okay,
So here I'm
I'll go through
provided
the
with
images for
CT
you.
contrast. Okay, these are the CT angiography images of this patient. I'm just looking mm, at the vessels. Okay, and to look for any aneurysm. Um, so the vessels on the left side, the veins appear to be very much tortuous. Superficial veins appear to be very much tortuous. And now I can see that there is some tangle of vessels noted on the left side in the region. The left middle cerebral artery also appears to be prominent. So,
What's your final
okay,
diagnosis?
so this is a hemorrhage from AV malformation. Okay, and so this AV malformation is supplied by middle cerebral artery and is drained from the cortical vein, and this is in the region of basal ganglia. And in my routine practice, I would measure the size of aneurysm or AV malformation, whether it is less than 3 to 6, or more than 6 centimeter. I mean, I would do the Spatzer-Martin classification. This is a eloquent area, and I would also check whether it is draining into the superficial or deep vein. In this, it is draining into the superficial vein, and I will also look for intraneedle aneurysm, which are very common in this AV malformation. This patient will need urgent referral to the on-call neurosurgical team, and yes, and they will need into urgent coiling. I think urgent coiling has to be done for further
What will they
management.
coil?
I think no. I think they do embolization.
What will they embolize?
Yes, sir. Embolize. I
Yeah.
think first,
Excellent. Good
first,
idea. This
first
is a
is
tricky one. Yeah. Good answer. The
first
problem is that this is such a huge AV malformation. Where do you start? And unfortunately, it's also bleeding as well. So the bleeding itself is naturally obviously causing a huge problem. So anyway, very nicely described. You've got all the findings that were necessary in this case. So it's a bleeding intracranial AVM. So again, these are the kind of patients, the kind of simple stuff you can also mention as well. With anyone who's had an intracranial hemorrhage, the first thing you want to make sure that they are doing is sort of, you know that they're going to do it anyway, but you need to show off your knowledge in the exam type setting. So regular neurological observations, urgent finding that you've described it. If there's any change in neurological examinations, then a repeat CT. You're looking for specifically what you're looking for in the repeat CTs if there's any decline.
so in the repeat CT, probably um any any rec I'm not sure, sir.
What kind of stuff
Repeat.
would go wrong in this category? What would
Sir,
cause neurological decline?
vasospasm can happen.
Vasospasm will probably help him in this situation if I'm stopping from bleeding even more.
Um,
What kind of stuff would cause a neurological decline? Why do these patients deteriorate? What happens?
so there is the blood goes, and I think the coating of the probably hemosiderosis. I mean, it coats the brain surface
Yeah.
probably.
So
And
remember, there's twofold. So number one, if you have blood in the ventricular system, you're very high risk of hydrocephalus. If you have swelling like you do have there, there is some midline shift. If you get worsening swelling, worsening hematoma, you'll get propagation of that midline shift. The parafalcine can cause a problem. It's those uncal herniations and the actual foramen magnum herniations, tonsil herniations that are life-threatening. They're all life-threatening, but one maybe slightly more than the other. But you're really looking for worsening swelling, a mass effect, herniation, worsening of the bleed, and also intraventricular extension worsening and hydrocephalus. So these are all things which, whether if they're deciding to managing it conservatively, it may prompt them to look further, or unfortunately, it may mean that's the time you palliate the patient. But decisions can be made as a result of that scan. Okay, excellent, nicely done. Right, let's move to the next case. So hopefully this will be a fairly quick one for you. This patient presents with worsening headache and vague neurology. I have multiple sequences. What do you think is going on? So I'll go through the first sequence for you. So headache and vague symptoms on the left side, a bit of weakness on the left side.
Okay, so these are the diffusion weighted images of a patient who has presented with headache, and in which I can see that there is a
I'll give you all of these sequences so it makes your life touch easier.
okay, so there is a area of diffusion restriction noted in the right frontal lobe, which on GRE images shows peripheral blooming. And on T2 weighted images, this appears to be hyper intense on T2 weighted images and also hyper intense on T1 weighted images as well. This has this is a hypodense rim, well-defined hypodense rim. And okay, so this patient has a history of worsening headache. Uh, and on T2 weighted images, I noticed that there is no significant perilesional edema. So this is bright on T2 and T1 weighted images. So I suspect that this could be blood, subacute blood, which is also showing diffusion restriction. So this is in keeping with late subacute hematoma. Um, it is a hemosiderin rim all around it. So could be so I would so are these the only images we have?
Just stop there for a second. So you've already given me a diagnosis.
Yes,
So
sir.
this is the point I was making before. You give me a diagnosis, perfect, move on. The more you're looking for new
So
findings, the
this
more
is
you're looking for something that's not there.
a subacute late subacute hematoma, sir, in the
Perfect,
right
move on.
section.
You've got the diagnosis, tell me the management now.
So urgent refer. I mean, this is not having significant perilesional edema. This is not causing any mass effect. I think the patient can be kept on follow up because there is no any subarachnoid hemorrhage seen, no subarachnoid hemorrhage seen. The patient can be kept on follow up and follow up imaging to look for resolution because it is just a single hematoma. Probably the patient can be kept on follow up or
Perfect. Excellent.
and
So exactly right. So you've described it quite nicely. There's some characteristic papers. I think this figure of 9 is the one I used to remember quite a lot. I do, and there's another one I can never remember it. Some BBDDOD, something like that. Someone keeps mentioning it to me. I can never remember that. It's too much of a tongue twister for me. For me, I've sort of pictured this image in my mind, and this is what I've really used, especially for those more common intraparenchymal sort of basal ganglia hemorrhages, just to date them, try and figure out what the timescale is. But you're exactly right. Your description was perfect. I thought you described it really well. Again, the key recommendation, and this is the purpose of these kind of sessions, is you've got the diagnosis, but for some reason you're not moving on to the next part of the conversation. You nailed it. You described and you exactly factored in why you thought this was even differentiated that this was a late subacute. So your description was spot on in this case. But this was really a time for you to show me the rest of your knowledge now, as opposed to going back a step, trying to look for something that isn't there. So just be careful you don't get caught in that trap. Unfortunately, it's an endless loop. You'll be there for the next half an hour trying to look for even more findings. Okay? But your
yes.
description is good. So anticoagulation. Can this patient restart anticoagulation now?
Uh, I think, sir, no, sir. This is, I think, not the anticoagulants.
Why?
This may bleed more, I think, because I think so.
Or if the patient has a metallic heart valve?
Uh, yes, sir. Yes, sir. In that case, antibiotics can be given. I'm not sure about the anticoagulation. I feel that it may bleed more if we start with anticoagulants.
So there are a lot of trials that have been done. They're not trials necessarily, it's more studies and some review articles. There's slight mismatch in consensus, but generally speaking, most people are happy to restart full dose anticoagulation depending on the risk. So if it's a high or moderate risk of stopping anticoagulation, for example, in someone who has a metallic heart valve, they'll probably restart this within the next few weeks, 2 or 3 weeks. Hassan, correct me if I'm wrong if you've heard elsewhere, but especially when someone's in, for example, AF, high risk of stroke, or DVT, or a PE, you can actually restart it once it's showing features of subacute hemorrhage. So they even say 4 weeks sometimes, but I think other people say 3 months, some people say 6 weeks, some people say 6 months. There's a bit of a range of times. But generally speaking, yeah. What
I
do you think,
agree
Hassan?
with you. I don't think there's a set. It varies from which trust you're working for, and it also varies from radiologist to radiologist. Although generally, one department should have a consensus of what they want to keep there. But yeah, as you said, subacute you can start um, coagulating them, give if they're high risk enough from like a PE or a DVT.
Absolutely. Perfect. Yeah. So in this case, forget this last bit. I think I just left it from the previous slide. Do you need to refer to neurosurgeon? Actually, you told me in your answer already. You're right. This is not an acute presentation. It does not need to be referred necessarily to a neurosurgical team. They're not going to do anything about it aside from recommend some more follow-up and clinical observations every now and again. Perfect. Nicely done. Right. So let's move on to the next case. Right, this patient, young patient, 40-year-old, presents with sudden onset left-sided weakness. A
Okay,
CT
so
head was initially normal.
okay. So here I'm provided with CT head uh, angiographic images of the patient who is presented with sudden left-sided weakness. Okay, so I'm just looking at the vessels. Anterocranial, okay, ACs appear normal. Anterocerebral were normal. I'm just quickly checking the internal carotid arteries, bilateral ICAs, and the vertebrals. So sorry. So the patient had left-sided weakness, as I can. Yes, sir. Okay. So bilateral vertebral appears to be normal. Okay. Just checking the course. The bilateral carotids also appear to be normal. Checking it cranially. On the right side, I suspect that there is severe. Sir, just could you please show me the right internal carotid artery, sir? I'm not able to see the right internal carotid artery. The lumen of the right internal carotid artery is not well appreciated on the right side. Uh,
Okay, what do you think is going on there?
so there is I think the right internal carotid artery is very faint. The suddenly it has become very faint. Could be probably because of dissection in this patient. If the patient is young, most likely the cause is dissection. I would like to see the other sagittal or the
So let's
coronal
just say you've
support.
reported this. The clinical team don't believe you. They say prove it.
So then I would like to see the brain images as well to look
They
for
don't believe
any.
your CT report. The CT's done. You've said query dissection. They said we don't believe you. What's your next option?
So then digital subtraction angiography has to be done, sir.
No one is available from IR to do this one.
Sir, time.
But it
So
is during
time.
the day. It's now 11 o'clock in the morning.
Um, sir, MRI can show the infarcts in
Okay,
the.
let's an MRI. What sequence would you like?
So I would like to see the diffusion weighted images
Diffusion weighted. Okay. Anything else?
and
You can pick
time
3
of
sequences.
so time of flight, diffusion weighted, and
Okay. But there, so what sequence can you potentially use that proves your point of a dissection? What's the one
uh,
sequence that will nail that diagnosis for you?
so so the loss of flow, so T2 weighted images and the diffusion weighted images to show the watershed infarct and the T2 weighted images to show the loss of flow void and time of flight
You've got loss
probably.
of flow void there technically in the on here.
Yes, sir.
This, so you don't really, so that doesn't really prove anything more. There's one sequence you need to show me that would
Yeah,
tell me
remember.
for sure.
So yes, so the T1 weighted fat sat images, the T1 weighted fat sat.
Okay, so let's go to the MRI.
Okay.
Right, what do you think?
Okay, so these are the
It's not really
okay.
fat sat, but nonetheless, what do you think? Actually, no, it's here. That's why I've put one on.
Okay. So on these images, again, I noticed that there is a crescentric hyperintensity noted in the lumen of right internal carotid artery. So this is in keeping with the dissection, and this is extending till the before just before the. So in my routine practice, I would like to see the extent and yes, and
Okay, perfect, excellent. So management, what do we do next?
Um, so urgent neurological referral, and yes, of course, I would like to see the um,
Forget the imaging, no
ur-
more imaging. It's just purely management now.
so urgent stroke team referral,
Yeah. Okay.
urgent stroke team referral,
Yeah.
and uh, if it sir, probably the patient has to be started with urgent thrombolysis if there is no hemorrhagic transformation, and if it is still in the golden hour, if it is still in the before the 4 hours, urgent thrombolytic treatment has to be started, and yeah.
Okay, fine. So there's a few more points you can make with this one. So I'll go through my slides in a second and hopefully that'll make sense. So you're exactly right. So dissections, typically they're found in young patients. Obviously, I didn't really give you the luxury of different free formats, but you tend to find this sort of flame-shaped, tapered appearance of the opacification. And that's really where the intimal flap is torn. But there's this other one, they call it this pseudo-occlusion. And what tends to happen, especially if you have a very big dense MCA infarct or carotid T infarct, it's actually sluggish flow that really slowly opacifies the internal carotid artery that causes this gradient type effect. It's really this flame-shaped opacity, which is really the one that's going to give you the information. Plus, you can sometimes see the intimal flap on the vessel wall. The danger in these kind of situations is number one, if there's an intimal tear, it can compress the lumen the more it expands, so blood flows into the channel, usually between the media as well as the muscularis. It spares the adventitia. And as this expands, it can actually block the lumen, like it has in this case, or even if it's subocclusive and it's just causing some stenosis, if there's an exit tear, you can actually get acute thrombus formation, and these can break off. And those can cause and shower acute infarct as well, which is why you typically need to take these kind of cases seriously in a young patient who's got convincing signs of an infarct. You need to proceed to a CT angiogram earlier than later. So exactly right, urgent finding to the stroke team, not necessarily neurosurgeon. Remember, the reason I keep saying this is because time and time again I keep saying neurosurgeon, neurosurgeon, neurosurgeon. They do not do every single thing in the brain. There are other teams involved. But neurological observations again, anticoagulation, antiplatelets. You're right. So potentially there is a role for thrombolysis, but it's actually what do we do going forward? Like I said, this patient will keep having thrombus and keep flying out. You'll never clear the thrombus there, but they're constantly going to be at risk of showering emboli. So they need long-term anticoagulation or antiplatelet therapy. There's some difference of opinion which one. I think if it's a young patient, they'll typically still get antiplatelets. If it's an older patient with other risk factors, such as AF or previous DVTs, they'll go for full dose anticoagulation. But also, these young patients, remarkably, they actually recanalize fairly well within 3 months. So the follow-up CT is very important to make sure that's happened. Okay. Right. So I think we are at the stage of a natural break. Very well done, candidate two. Very nicely described. I'm very impressed with the answers. I think we'll have a quick 5-minute break. Unless Hassan, sorry, did you want to come in or anything before we?
Yeah, I was asking, Saki mentioned that you have to request a CT angiogram, but be specific that you want a CT angiogram from the aortic arch to the circle of Willis, because if there's if somebody's got multiple emboli, bihemispheric, especially, multiple infarcts that appear acute, they're usually embolic in nature. And even, if you're suspecting that, then you should always be specific on the type of angiogram you're asking for. We're not just doing like an intracranial angio, we're doing one from the arch all the way up to the circle of Willis, because you want to see the entire length. And if there is a dissection, you want to see how far that's going or any other cause that might be happening. But that's it. The rest is fine. Yeah.
Excellent. Right. Thank you very much, candidate two. So thank you, everyone. So we'll have a quick 5-minute breather, and then we'll carry on. So if we reconvene, actually 4-minute breather at 7:45 UK time, and then we'll carry on. And then candidate three hopefully will join you with us shortly. Excellent. Thank you. See you shortly. Right, thank you very much, everyone. Sorry, you just had to be unmuted. Thank you for joining again. Right, so let's get straight into it. Candidate 3.
Hello, hi.
Hi, how are you?
Fine, thank you.
Excellent. So you've got hopefully a bit of an idea how we're doing this session today. Remember, I'm not too focused on the actual imaging interpretation, although we'll go through some factors, but it's really to try and push you to give me a good attempt at the management, how to keep that conversation going, like I said. So any questions before we start?
No, thank you.
Okay, can you see my screen?
Yeah.
Excellent. I'll keep scrolling like I've been doing for everyone else. If you want me to stop at a certain image, I can, if it comes to it. Right, so I'll show you the next case. I have a patient who has severe lower limb neurological symptoms, loss of power in L5 territory and L3 territories, but he has a pacemaker. We cannot identify the make, brand, or model.
Yeah.
What do you do?
Okay.
What kind of options does he have?
So we cannot identify the type of the pacemaker, so he cannot undergo MRI.
MRI said in no circumstance he can have an MRI.
Yeah.
Next option, please.
And we are facing like lower limb neurological symptoms, lower limb bilaterally.
Yeah.
So our main concern is the something in the spinal cord. CT.
CT. Okay. Anything else? Okay. Let's move on then.
For the core.
Right.
Okay.
What do you think is going on here?
I'm not really familiar with the procedure. I mean,
Okay. So I'll help you talk through this one. So you can see that it's a fluoroscopic image. This is a needle, a spinal needle. So what do
yeah.
you think is going on? What are they doing?
It seems like I thought we don't do myelographies anymore.
Oh, we do it all the time. What else do you do for patients who can't have MRI?
Excuse me?
What else do you do if a patient can't have MRI?
Yeah, I didn't know. Yeah, I'm sorry, I didn't know we can do it. Okay, so
So
this
talk me through this one then. Now that you know it's a myelogram, tell me more.
I have. Oh my God, this is head and neck.
We'll talk through this one because again, this is exactly the reason I show this one. Until you see it for the first time, or you never know it exists. So this is why. So hopefully, if you learn something, I've done my job for today. So the idea is we use a spinal needle, very similar to a lumbar puncture, using X-ray guidance. Guide a small needle into the spinal canal, inject some contrast, ideally in the location that we don't think is affected. If you suspect that there's a problem at the L2, L3 level, then you do not want to be putting the spinal needle in the L2, L3 level. So it's based slightly more on clinical symptoms. But look at this. This is what the spine should look like. These filling defect strands are the actual nerves of the chordae equina themselves. And you won't really see the cord itself because that will just be one long big filling defect. It's more this contrast around the spinal nerve roots themselves. So what do you think about the spinal canal itself at all levels? Do you think there's a difference up here to this one, to this one, to this one?
Uh,
What do you think is going on here? Look at this space. Compare that to this. What do you think of the space? Can you see here? What do you think is going on here? Right there. Can you see this bit here and this little bulge here? What do you think is happening here at these two areas?
there is narrowing. There is
Yeah.
yeah. So yeah, the spinal sac, the sac, the thecal sac itself is narrowed at the level of at these two levels.
Yeah.
Like the nerves. I mean, I cannot. The coda equina nerves are seen right here, and then the sac is narrowed here and here. So maybe this will be like due to disc bulges.
Okay, right. So whenever you do the fluoroscopy examination, that is not the end of it, because the next thing you do now is send this patient to the CT scanner and we do a CT.
Yeah.
Because now, let's scroll through this one and then you tell me where the problem is. So can you now see that there's contrast within the thecal sac?
Yeah.
Right. Follow that for me now. And tell me when you see a problem.
Yeah. Okay. So I am in front of the lumbar vertebrae CT. I can see that the vertebral bodies, the examined vertebral bodies show heterogeneous texture with multiple. Can you scroll upwards again, please? Yeah, it is heterogeneous texture with multiple sclerotic lesions throughout the vertebral bodies. Do we have a sagittal film? Sagittal view? Yeah. Yeah. So there is a heterogeneous ecotexture of the examined lumbar vertebral bodies with multiple sclerotic lesions seen throughout them, with especially the LV. I cannot see if this if this is SV1, if this is LV5, this LV5, LV4, 3, 2, and 1. LV1 vertebrae is heterogeneous, is so heterogeneous. So this is suspicious of metastatic bone disease. Considered he's a male or a female, and the age, please?
No idea. To forget the age.
So if I'm in front
Actually, male.
If the sclerotic mets in an older or a male, I'll think about prostatic cancer. If female, maybe breast, it can be lytic or sclerotic or mixed of both. This is the main. I cannot see like extravertebral soft tissue. Extravertebral soft tissue lesions, and this is the main differential. So the next step will be informing, but there was a bulge on the thecal, compressing the thecal sac. So can I see the axial again? I mean, I'm now looking to check for extravertebral soft tissue, lytic soft tissue lesions extending beyond the vertebral body that may compress. And so the nerve roots. Explaining his symptoms, yeah, here. So I can see a lytic lesion occupying the vertebral body and extending beyond it posteriorly.
Is that a lytic lesion?
It was a sclerotic bone mats, but I mean with the soft tissue component, with soft tissue component extending beyond the vertebral body and indenting, compressing, and inseparable from the thecal sac, and consequently the traversing and the lateral neurorecessive and the foramina. Of course, they are much better seen. The nerve roots, the traversing and the exiting nerve roots are much better seen on the MRI. However, from the myography and the CT, I can conclude the result that it's compressing the thecal sac and narrowing it, thus compressing the nerve roots and explaining the patient's symptoms. So I have to report back to the clinicians, the neurology clinician, that this patient probably has a vertebral metastasis, one of which is compressing the nerve roots. For them, suggesting for them that it may need. If it may need like a surgical intervention to decompress the nerve roots, and then for him to undergo to be examined by other teams to try to locate the primary. If I suspect he's a male with prostatic cancer, I'll maybe do the labs of the PSA. If it is high, it will be probably above 20 if it is with bone mats, and accordingly, I will just try to locate the primary.
Excellent. Right. Really good answer. I'm very impressed. Though the only thing I have to slightly, actually, overall, your management, this is brilliant. This is exactly what I'm talking about. Looking beyond what you're seeing directly from the screen and thinking about the patient overall. So number one, excellent job. It's obviously a difficult examination because unfortunately you've never seen it before, which is not, it's completely understandable. I'd never seen this before until maybe my fourth year radiology. It does exist, but it's just a reminder to people to keep an eye out, especially the two domains of radiology or three domains that I completely ignored or didn't put as much time or effort in was nuclear medicine, fluoroscopy, upper GI, lower GI, any part of the body that involves fluoroscopy. And number three, certain types of trauma. It's very easy to neglect trauma. You sort of just assume that it's going to be very extremely obvious to you. But head and neck trauma was a huge domain of radiology, which I ignored. So yeah, anyway, we've talked through what the purpose of the myelogram is, how we roughly do it. Contrast is now in thecal sac. So you were it's slightly confusing here, where because it's a trick question in the sense that there's lots of these metastases. You did really well in explaining what you think is likely, and this is exactly how I expect people to answer. If you see a patient with metastatic disease, it's good to estimate where did they come from, have some kind of a rational thought process, and it gives you an understanding. It shows the examiner you've got an understanding of common things are common and what kind of cancers exist in a certain population. So exactly right, sclerotic bone mets, you think of breast cancer or prostate cancer, depending on the gender. Nicely done. So the only thing is that you can see that the narrowing is at these levels over here, almost directly adjacent to the intervertebral disc spaces, where there's also, I'll show you the axial again, there's also facet joint hypertrophy, very subtle. But you can actually see the bones there, they're not really destroyed, are they? You can see the cortex quite nicely and preserved. And the
yeah,
location of these suggests rather than this being metastatic compression, this is actually just related to degenerative disease and disc disease.
yeah,
So this is sort of like two pathologies going in at once.
yeah.
Okay. The only thing with myelograms, you do find that actually you do get pooling of the actual contrast in the lower half. So a lot of the time, if you can try to transfer the patient while without them having to stand up, that's the ideal way of doing things. So they keep lying down, send them to the CT scanner, and make sure you sort of avoid them sitting up if you can. Excellent, fine. So I'll quickly very show you my screen. Give me a second. Yeah. So we did a CT scan. So yeah, exactly right. So the issue is in this case, remember, one of the mistakes I've always noticed with people is that they've always mentioned there is Cauda-Equina syndrome. Cauda-Equina syndrome means that there's clinical symptoms involved. Your question mark, the only thing you should be answering there is canal stenosis, what degree? Is there compression or crowding of the cauda-equina nerve roots? Or is there compression of the spinal canal itself? For you to make a diagnosis of this is an MRI showing cauda-equina compression, as a statement, it's wrong because it's based on symptoms, not based on necessarily the radiology. Patient may potentially be asymptomatic or very minimal symptoms. They only treat that if the patient actually has concerns or clinical Cauda-Equina syndrome. But yeah, you're exactly right. My word for word, you got exactly what I would have said for the malignancy side of things. So yeah, staging CT. Who needs to deal with this, the spinal or the neurosurgical team?
The spine, I mean, if the discs are to be treated, then the neurosurgical team, if they are considering the treatment of the discs. However, I think the main concern of the patient is the multiple mets.
Absolutely right. Exactly right. Yeah. So I spot on. So you can always mention as a side note that if the cancer is treated or stable, then they can be referred to the neurosurgical spinal surgical team. So you're almost writing a ward round plan for this patient. You have mapped out a plan for this patient for the next 2 or 3 or 4 weeks based on your one radiology report. And that's the stage you want need to get to. Bring clinical radiology back into radiology is my recommendation. Perfect. Nicely done. So let's move on to the next one. So, right. This is a newborn. A ultrasound was performed. What do you think?
A newborn ultrasound is performed. Okay, so what I see is there is a hyperechoic, both caudothalamic grooves are occupied by hyperechoic lesions extending into on the left it is extending into the frontal horn, on the right it is extending into the ventricle, and then beyond the ventricle. Is he preterm?
There you go.
Preterm, is the newborn preterm?
Preterm, indeed. Yes, yeah.
Yeah.
Good question.
So,
Yeah.
yeah, preterm. So I'm in front of a transcranial view of a newborn preterm, with a hyperechoic hyperechogenicity seen involving the both caudothalamic grooves extending into the frontal horn that seems a bit dilated on the left side, and the right side, and still beyond the frontal horn to the brain parenchyma. So my main concern that this is germinal matrix hemorrhage. If there are any other views up and down, if you can scroll or anything to see if it is really
Just this
germinal
one view.
hemorrhage inside just this one. So consider that he's a preterm and newborn, and this view, it seems like germinal matrix hemorrhage stage 3 or 4, because it is extending beyond it is causing enlargement of the ventricles and extending beyond the ventricles to the brain parenchyma.
Okay. So you're doing really well. Carry on.
So my next step would be germinal matrix
Just
hemorrhage.
as a quick side note, this is not the first time you've seen an intraventricular hemorrhage in a baby before. In your normal practice, what would you see or do for these patients?
These patients are usually in the NICU, so we inform I mean I scan for the complications of the germinal matrix hemorrhage and anything associated with it, as a periventricular recumbellation is sometimes associated with it, and I just reported back to the NICU doctors. That's it, actually.
Right. Would you do a CT?
A CT for germinal matrix hemorrhage?
Yeah.
In
this patient, would you recommend a CT scan?
In this patient?
Yeah.
Well, in this patient, I'm a bit concerned because of this echogenicity related to the. I'm not
Have
really.
you ever seen a CT scan in a neonate for germinal matrix hemorrhage?
No, not really, no.
That's why, because we don't do them.
Yeah.
Yeah, so stick to your gut. So exactly right, perfectly mentioned. Degree of intraventricular extension. Each one of these factors dictates what the grade of the hemorrhage is. Now, the idea is, why is the grading important over here? Just gives you a bit of an idea of what patients are likely to do well. It doesn't actually necessarily make an immediate difference in the long-term management. Although grade 1, grade 2 are expected to make a full recovery, grade 3, grade 4 are the ones who are slightly more prone to developmental delays, long-term issues. So really, let's think back clinically now. So you've made an assessment that this patient's got a grade 3/4, which I agree with. There's so much more we need to tell these patients. Again, a lot of these things are given, but again, this sort of brings back the whole idea of, you need to show off your knowledge. You need to show that examiner, not just that you understand the radiology involved, you understand what happens to this patient once they leave the room with you. So yes, it's an urgent finding. Clinically, it's head circumference measurements. That's what they deal with. And they'll mention on their radiology reports or their radiology requests, head circumference increasing, head circumference this, because they're obsessed with head circumference. Is because that's what they do. You need to check for signs of intracranial pressure with things like bulging fontanelle, drowsiness, hypotonia, things like that. Seizures. So these patients need to be managed with anti-epileptic medications if they have any risk of seizures. The CT was obviously a trick question. We don't do them. We've got such good imaging quality in the newborn and a neonate. We don't need to, as long as the fontanelles are patent. But yeah, neurosurgical management. Do the neurosurgeons do anything for these patients?
Not really. I think it's for follow-up. It's for follow-up.
What if he has severe hydrocephalus?
Yeah. If he has a hydrocephalus, then he has to get the ventriculoperitoneal shunting of the hydrocephalus. Yeah.
Exactly right. Yeah, if there's raised intracranial pressure, you keep that going, that baby will die. So although it's obviously not favorable to be doing a major operation in a newborn or neonate, sometimes these things have to be done to prevent further harm. But fine, good, excellent, nicely done. So the next case, I think majority of my cases are now, rather than PowerPoint, so I'll be switching mainly to DICOMs. So let me show you the next case now, which is this patient presents following a fall. I'll show you these images first. In fact, actually, do you want to try taking control? Let's see if it works for you.
1 second, I'll try. No, I don't know.
Okay, don't worry. I'll keep scrolling. Okay, right. So presents with blunt force injury to the right temporal region.
Yeah, I'm sorry. To the right temporal region, blunt force injury. Yeah, okay. I'm sorry because I misopened the screen. Can we just scroll again? I'm sorry.
Of course, no, that's fine.
Okay. So I have CT brain of the patient. I'm examining it. I'm looking through the brain parenchyma for any abnormality. However, I cannot really. We said the right temporal region, blunt force, right? Yeah. So what I appreciate what I see for now is air foci, intracranial air foci adjacent to the right occipital lobe, and Can we just scroll?
Bone windows then. Carry on.
So I'm examining the bones. There is opacification at the right mastoid ear cells and the middle ear cavity. I'm looking for fractures. It seems that there is a fracture going through the mastoid bone. I should determine if this is a longitudinal or a transverse fracture, because each kind of fracture will be associated with its own complications. It seems so, and most of the time it's actually a mixture of both. So I just have to see through the fracture, and where it's cutting the temporal bone longitudinally, extending from the temporal bone posteriorly at the mastoid, reaching the anterior portion of the temporal bone at the middle cranial fossa. We associated with opacification, as I mentioned before, the middle ear cavity and the mastoid process. Can I just if you can focus to if you can zoom in for the middle ear cavity structures to see if they are injured, because I should be checking the ossicle, the facial nerve canal, and the related the jugular and the carotid canal too. This is the endothelial canals, the inner ear structures. I can see the fracture reaching the middle cranial fossa. The jugular foramen appears fine. The carotid canal.
Okay, so summarize. What do you think of this one? This is the last image to review.
This is the last image I should examine?
Yep. What do you think here? Focus your attention here.
Yeah. Okay. There is a fracture here. Yeah, this is the fracture also along with the longitudinal fracture I mentioned before. The vertical fracture seen at the innermost part of the mastoid process. This is the inner the inner part of the mastoid process behind the extending, involving the posterior aspect of the jugular foramen, involving the posterior aspect of the jugular foramen. Yeah, this bone is separated, almost
What about
separated.
here?
Yeah, this is suture. Oh my God, I'm sorry. This is suture.
Right. So you give me lots of findings. What's your management now? Give me one line of a summary.
One line of a summary. So I'm in front of a patient that had a blunt trauma to the right temporal bone with consequent fracture of the right temporal bone, longitudinal fracture traversing the whole right temporal bone with consequent opacification of the mastoid, likely consequent opacification of the mastoid ear cells and the.
Stop. Your one line has become the whole report again. Just one nice, beautiful, succinct conclusion.
Okay, longitudinal fracture of the temporal bone.
Beautiful, done. Excellent. That in itself has told me exactly what I need to be worried about. One small statement that you need to add on to there. Is the first finding you've told me.
The facial, the reaching the middle cranial fossa.
No, the very first finding you found on the normal CT brain.
Associated with a few air foci, the intracranial pneumocephalus. Yeah.
That's it. Longitudinal fracture of the right temporal bone and evidence of pneumocephalus. Yes, there's some additional findings. Yes, there's additional fracture patterns. Those two are the most serious things I need to know about for the time being, unless there were additional findings you found. But that is your concluding statement. Now, what's your management?
So given that it is a longitudinal fracture with no obvious related complication like the facial nerve canal dehiscence or jugular or carotid canal affection, so it will be I report back to the clinicians. I think it is through the ENT team, yeah, and it will be like for follow. I don't know. They treat it follow up, right?
So again, the part of this is going to be based on neurological symptoms. So yes, you're not finding a clear disassociation with the ossicles, but you need to tell them, have there any issues or any symptoms of facial nerve palsy, hearing loss, sensorineural, I've got the other one, it's mind blank. What's the other one called?
Conductive hearing loss as well.
That's conductive hearing loss, yes. So you need to differentiate, are there any of these additional symptoms? Whenever you see pneumocephalus, these patients are at a much higher risk of meningitis now. So they have to have antibiotics on board. These are the kind of clinical points that you need to be making. Pneumocephalus instantly, regardless of the degree, the extent, what it's associated with, risk of meningitis is there as well. So there's a few additional findings over here. It's the maxillofacial team and their base of skull team, the head and neck team. Lots of people are usually involved in these kind of traumatic issues. But yeah, that's the key thing. There's signposting to the examiner that you understand what this patient needs next. Okay?
Yeah.
Excellent. Nicely done. So we'll do one final case for you before we move on.
Okay.
Right. This patient presents with worsening weakness and tingling in the hands and the arms. I'll scroll through for you.
Okay, thank you. So I'm presented with a sagittal T2 MRI of the cervical spine and the base of the brain. Of course, there is straightening of the spine with a disc bulge here, but what is the main finding is the posterior T2 hyperintense posterior, the long segment hyperintense T2 patch seen along the posterior cervical cord, almost involving the whole cervical cord. If there are any other sequences like axial T2, I'd like to see. Yeah, so there is obvious involvement of the posterior aspect of the cord with the inverted V-shaped sign affecting the T2 hyperintense inverted T2 hyperintense signal affecting the posterior aspect of the cervical cord. So my main differential diagnosis will be vitamin B deficiency. I think it was niacin vitamin B deficiency. It was B6 or B612 niacin deficiency. So I'll report this back to the neurology team, and the main cause for this is usually I report this back to search for the causes of vitamin B deficiency that include alcoholism, malabsorption, malnutrition. For them to replace the vitamin B deficiency and for the patient to get treated.
Excellent. Very good answer. Perfect answer. One other cause, which is probably, I'm not sure if you've come across it a lot, it seems to be extremely prevalent in the UK at the moment. There's nitrous oxide. I'm not sure if you mentioned that. So drug overuse essentially from nitric oxide. It can actually cause fairly acute B12 deficiency. But again, this is where you need to nail the management. You clearly know this stuff. How do you manage this? B12 replacements. Keep it simple.
Yeah.
But again, this is where obviously once you see the fact that inverted V sign, these are neurological signs, a way to show off your knowledge even better is to try and be a bit more precise from an anatomy point of view. Explain that the dorsal columns have these linear long segments of high signal. So if you're explaining exactly where in the anatomy of the cord that's affected, and then you can say this gives the inverted V sign. What that essentially shows that you've got some understanding of what the actual pathology is, rather than blindly looking for a radiological sign, if that makes sense.
Yeah.
Yeah, but very good answer. Excellent. Right. Sorry, candidate 3, only in the interest of time, I have to move on, but very well done. You did excellent there. Thank you very much. So candidate 4, are you with us?
Yes, sir.
Perfect. So all set to go on your side?
Yes, sir.
Right, fine. So a couple of these will be fairly quick fire questions. I just want you to give me a fairly spot diagnosis and give me some form of an attempt of a diagnosis, management, and go from there, okay?
Okay.
Patient presents with worsening lower limb bilateral weakness, arms and legs affected.
Okay. I'm presented with the T2 axial slices of a brain MRI of a patient who presents with worsening of the limb weakness. I would take a moment to go through the images. Okay. So the obvious abnormality which I can spot is that there is a T2 high signal intensity focal area involving the pons. Okay, it is not causing mass effect, and I would like to see this area on other sequences also to...
Okay, I can show you a sagittal T2.
Okay, on the sagittal T2, I can see that this area is posteriorly well defined in the center of the pons. I can also see some gyration sort of on the posterior part. However, there is no mass effect on the basilar artery, or the prepontine cistern appears normal. In my routine practice, I would also like to see the rest of the sequences to comment on the lesion.
What other sequence would you like?
Okay, so as the location of this lesion, I would like to add the differentials of osmotic demyelination, and I would like to see the diffusion restriction in this lesion to comment on this.
I only have DWI, but just comment on the DWI.
Okay, so on DWI, it shows high signal intensity. So this can represent osmotic demyelination, and the other differential could possibly, I would like to see the rest of the sequences, but I would like to ask the history if the patient has a recent correction of the hyponatremia, or admission in the ward for any correction of the osmotic imbalances. Otherwise, if the patient is asymptomatic and this is an incidental finding, then I would also like to add the differentials of focal pontine lesions could be related to simple pontine telangiectasia, or less likely this is to be a pontine glioma, because it would cause symptoms and the patient might present with the symptoms. So I would like to see the rest of the sequences to confirm my findings. I would convey the findings to the referring physician, and then if it is an osmotic demyelinosis, then I would inform the primary physician about this finding, and they might correlate it with the history. I can also follow it up on the subsequent MRI to see the resolution of this finding.
Would it ever resolve?
Sorry?
Does this ever resolve?
Yes, it can resolve in the follow-up MRI.
Okay. So if you do that, so what do you think is, so once you have that, do you think it's still CPO then? Or CPM, sorry.
Yes, because it is actually it is because of rapid correction of hyponatremia. So it is basically
Is that the
osmolar
only cause?
imbalance. Yes.
Is that the only cause?
So that's the cause which I know about.
No, fair enough. That's fine. So excellent. Very good description. So you're right. This is exactly that. Central pontine myelinosis. They call it something else. Something to do with osmotic something, something, something. That's the only, you're on mute, Hassan. I can't remember what the other name is.
I was going to say it's the osmotic demyelination syndrome.
There we are. That's it. Well, so yeah, the differentials are reasonable. I mean, yeah. So, correct me if I'm wrong, Hassan. I was always told that these are irreversible, supportive treatments only. But I wasn't sure that you follow these up, unless there's something a different practice that you have, Hassan.
So, I mean, you treat the hyponatremia, which is a common cause, but the survival rates for this, I mean, some people show they're fine, but actually survival rates are not good after this, not a good condition to have. So follow-up is entirely dependent on whether the patient's going to survive.
Yeah. And I think it's something abysmal, like less than 5% within a space of 2 years, something along those lines.
Very
Quite poor survival. And usually it's irreversible damage, which is why it's such a debilitating condition in these kind of situations. But exactly right. Very nicely done. You described what you were thinking about. It could be related to secondary hyponatremia. You're exactly right. So the neurological people need to know management is really best supportive care, but the only question that you got to raise is from an imaging point of view, can you rule out other potential causes? Although the sort of location of this is fairly classic, people do mention sort of acute infarcts, but then so when you talk about differential diagnosis, if you think back to when you were in medical school or foundation type training, when you talk about differential diagnosis, you said you're most likely and then other potential options and why they're not your most likely, just to keep the conversation going. An infarct's in differential because of the high diffusion restriction. However, it doesn't fit the right location for an infarct. You typically would expect it to be eccentric as opposed to central pontine. You could say demyelinating condition as a potential option in multiple sclerosis, for example. But again, the location really isn't typical for the demyelinating plaques that you see. So really, CPM is really the top differential here. So nicely done. Right, let's move on. So I have shown this case a few times before, so if it's familiar to you, please tell me and I'll move on. Okay?
Okay.
Oh, that's not it. Never mind. Sorry, give me a moment. Right, this patient presents with severe worsening headache and right-sided weakness.
So I haven't seen this before. Okay, so I'm presented with the non-contrast CT scan of the brain of a patient who has right-sided weakness. Uh, okay, so I can note that there are multiple hyperdense focal lesions involving the left frontal lobe and the left posterior parietal lobe, and there is surrounding vasogenic, okay, left cerebellum as well. There is surrounding edema, and I can also see, okay, I can see that the patient also is having a hypodensity in the right cerebellum. I would like to see it. Okay. There is a dilatation of the bilateral lateral ventricles, and okay, so I can see that there is a diffuse hypodense area involving the right cerebellum. It is causing mass effect on the ipsilateral middle cerebellar peduncle, as well as there is mass effect on the fourth ventricle. In my routine practice, I would like to see the sagittal view for possible coning or crowding at the foramen magnum. These limited slices demonstrate that there is okay, so there are multiple hyperdense focal lesions in the brain. Okay, there is a crowding noted at the foramen magnum because I can see that there is effacement of the CSF sleeve along the um, medulla oblongata. So I would like to, I would go back to ask the history of the patient, if the patient has a previous imaging or it is the first time presentation, because I'm thinking that these are very well defined focal hyperdense lesions. So there is a possibility that these are metastases. I would like to correlate with the patient history for any known primary in this case. And furthermore, I would also like to I would also like to advise the MRI for this patient to see the extent of these lesions, the number of these lesions, and I would also inform my findings to the referring physician, and I would also tell them urgently that there is a lesion in the right cerebellum and there is significant mass effect, and I would involve as I can see that there was mild hydrocephalus, so this can go on to develop a gross hydrocephalus, and I would also take the neurosurgical opinion on this case. So that's
Excellent. Good. So good description of the cases. I think again, one of the key things is try to avoid, once you've given me a description of the findings, keep it simple. Try to avoid falling into that trap that I keep telling about describing new findings or trying to reiterate the same findings. Once you told me that there's a cerebellar mass, that's it. I'm happy. You've told me it's cerebellar mass. The only thing I want to know is what your differential diagnosis and what your management is. I know you're sort of rationalizing, explaining why. I think you can make it slightly more succinct. Your answers you're perfectly reasonable and rational, but especially in time conditions, you just want to make it nice and flow off your tongue. So the key thing here really is here, hemorrhagic metastases, large lesion obstructing the fourth ventricle or causing effacement of the fourth ventricle. Those are the key terms here. So yeah, exactly right. So this case, have you ever heard of an acronym? The only one I've used is Mr. CTBB.
uh, no, sir,
So
I haven't.
I think that I'm sure there's other variations, but it just gives you the six most likely causes of, I don't think in order of necessarily of applicability, but melanoma, renal cell carcinoma, thyroid cancer, choriocarcinoma, I think
Yeah.
it was, and it was bronchogenic carcinoma, lung lesions, or breast.
Yeah.
Okay.
So showing some kind of an appreciation of the likely cause of hemorrhagic metastasis makes you think of where you should be looking. But either way, this patient needs a clinical examination, staging CT scan if not known to have a malignancy. You can offer to say these are the kind of most common tumors that cause hemorrhagic metastases. But again, you're exactly right. Neurosurgical referral because there's a high risk of developing further hydrocephalus. Excellent. Nicely done. Right, let's move on.
I think it's also important to mention if you see multiple lesions, you should just say, you know, that's one of the reasons why I think this is METS. And also with METS, especially with brain METS, you'll often find that the edema that you get, the vasogenic edema associated with it, is completely out of proportion with the size of the lesion. So the edema is much more than the actual size of the lesion for a lot of the intracranial metastases that you get.
Yes, sir. Thank you.
Okay, perfect. Right, so we're going to move on. Right, this patient has worsening and severe headaches, intermittent. I'll scroll through the images for you and tell me if there's anything you see or want me to stop at. I do have other sequences as well.
Okay. I'm presented with a T2 axial slices of the brain, and I can see that there are multiple periventricular white matter scattered lesions. I would like to, can you, sir, scroll one time? Okay. I can see that, okay. So these are located in the periventricular white matter, the subcortical white matter as well. There is a prominence of the subarachnoid spaces, could be related to cerebral atrophy, but I would like to correlate with the age of patient. I'm looking for any focal lesion, but these are multiple. And okay, these are multiple, and I would like to see the rest of the brainstem, midbrain, and the posterior fossa as well for involvement of these areas.
Okay, what I'll do, I'll show you another sequence anyway. Actually, what to do, let me show you 3 of the sequences, and then you can review all of them.
Okay.
So if I was to stop at this slice here, what do you think?
So I think that there is a focal area of gyral swelling, which is of T2 high signal intensity in the paramedian location on the left side. Other than this, I'm looking for, okay, I can see that the rest of the brain shows normal sulcal gyral pattern. There are some focal T2 high signal intensities scattered in the subcortical and the periventricular white matter. I'm looking on the post-contrast sequences as well. I do not see any significant enhancement or any focally enhancing lesion. Okay, so I can see that there is somewhat prominence of the dura on the right side posteriorly, but that could be related to the atrophy in the posterior parietal region. Okay, I'm looking at the extra-axial spaces as well to see any focal lesion, which I cannot appreciate here.
So I can go through another slice. So what do you think of this slice here then?
Sir, I think that, okay. Sir, I think there is like loss of the cortex of the gyri. So could be
They're all
related.
normal.
Okay, they're normal. Uh, Other than this, I can see that there is a okay, there is a skull thickening and there is
Normal.
some okay.
Something you mentioned, but you dismissed.
Dura, I mentioned about the dura that
Okay, tell me more about that.
I feel that it is little, it appears to be slightly thicker. Like I can see that on the post contrast images as well, there is a diffuse dural enhancement, and which normally we do not appreciate this much a thick kind of dural enhancement. And I'm looking for any cause of this, but I cannot locate any cause. And I would also
What
like to
cause are you thinking?
Okay, so I'm thinking that if the patient has multiple headaches, then it could be related to something which is a benign intracranial hypotension, because this could be related to the distension of the sinuses and can cause pachymeningeal hyperenhancement. I would like to see the other features of the condition, and I would like to see the sagittal for the any tonsillar ectopia, or I would also like to see the pituitary gland for enhancement or a focal
Those are
mass.
normal. So just finish off with your main differential then.
So,
Well, give you a concluding statement.
okay, so this is a smooth, diffuse enhancement of the dura, and which appears slightly thickened as compared to the normal. And
So stop there. Remember, one line statement. So you were perfect. The first few words you said were excellent. No need to say any more.
okay.
So excellent, right? So tricky one, because in these kind of cases, even the first time I saw this, when I was, it was actually put on part of my reporting pile. Something didn't seem right. I couldn't figure out what wasn't right until we saw the T1, which I only really ever see the T1 as a problem-solving scan in most of the MRIs I report, and that's where it was really obvious that there was this sort of diffuse thickening of the dura all the way around. And eventually, this patient ended up having a post-contrast scan, which confirmed quite avid enhancement of the dura all the way through. So this is diffuse dural thickening, but with the history involved, one of the key differentials here is cerebral hypotension, and that causes sort of recurrent cyclical type symptoms. Now, the other thing is meningitis that can cause dural thickening.
Yes.
The other thing is, and it's typically more leptomeningeal enhancement, but again, lumbar punctures can do the same thing. Hassan, anything else you can think of? Yeah. So, next question for you then, Candidate 4. Shall we perform a lumbar puncture?
Sir, if it is hypotension, then it will worsen the symptoms for doing the lumbar puncture. Because it is usually caused because of the dural tear, or there is some CSF leakage which is going on. So I would not advise the lumbar puncture. It will make it worse.
Excellent. Very nicely answered. Perfect. Right, let's move on. So I'll give you one last case for the day. So this patient presents with a swelling and lump in the neck, as well as some difficulty swallowing. I will go through the images for you.
Okay, so these are post-contrast T1 images of a patient who has a difficulty in swallowing. Okay, so I can see that there is enhancing well circumscribed mass lesion noted in the right
Is this
side
a
of.
post-contrast scan?
Yeah, yes, sir. Okay. So I can see that there is actually a focal soft tissue thickening, which is noted in the right fossa of Rosenmuller, and which there is slight effacement of the pharyngeal soft tissues as well in this area. Yeah, this one. And okay, and I can also see that there is a contiguous multiple enhancing rounded lesions in posterior in the retropharyngeal space, as well as in the right. Okay. This is okay. This is in front of the parotid. So these okay, these are enhancing, and there is a soft tissue in the pharynx as well. So I'm thinking that these can most likely represent malignant etiology in this patient, and because he's also having swallowing difficulty, so I'm thinking that this could represent a a squamous cell carcinoma or a nasopharyngeal carcinoma. And as this is not involving purely the nasopharynx, but there are contiguous lymph nodes I can see. So these most likely represent the nodal metastasis in this patient. Furthermore, which I would like to do in this patient is that convey these findings to the referring physician that I am thinking on the lines of a malignant etiology mass, which is causing nodal metastasis. And I would advise I would also like to refer the patient for the possible biopsy of the mass. For the ENT referral, and then we'll discuss this patient in the MDT, and would also like to do the rest of the staging workup and to rule out the possibility of distant metastasis. These images, I would like to see the brain as well, and to see any intracranial or perineural extension, which is not usually related to these kind of tumors, but I would still like to review the images. And I can also see that the lymphadenopathy is fairly on one side of the patient, so that would also be helpful in staging. And
Okay, just stop there. So your answer has been brilliant. Okay, there's one side thing of it, but now you're sort of getting caught in this loop of trying to say more things which are unnecessary. The problem is that the examiner can sort of sit there and let you keep talking, but nothing you're saying anymore is adding any more value to what you've already said. You've already given what I would classify as nearly a gold medal answer. It's brilliant. It's exactly what I need to know. But then at some point you need to stop. I know it's slightly weird and
quiet,
daunting.
so
You
I
don't know
thought that I
when.
should keep on. You were so quiet, so
No,
I
but
thought.
I mean, but you should have the confidence that you have truly said anything and everything you need to say. You've given me the differential diagnosis. You've given me the next stage of the management, who needs to be involved, how to get tissue sampling. The only criticism I really have is that you kept calling this a post-contrast scan, whereas this is actually a non-contrast fat-saturated stir. This is the post-contrast scan. So I'll show you them side to side so you can think. So just be slightly careful. A lot of the time, people just say fluid sensitive, fat suppressed imaging, and that normally helps. This is the post contrast scan here. Can you see
Okay.
that there's a very distinct difference between the brain parenchyma in both?
Yes, sir. Yes,
But
sir. Now.
also the muscle as well. Look at the mucosa, look at the muscles, the way they're enhancing. So just have an appreciation, especially if it's a domain of radiology you're not often seeing in head and neck radiology and you're not using head and neck MRIs. Just having an appreciation of the kind of sequences they use and you come across, just so you don't get caught out in the exam.
Okay, sir. Thank you.
Because I would have made the exact same mistake as you. But again, the only thing I really look for, can you see the very distinct difference between the posterior fossa on a post-contrast T1 versus a stir?
Yes, yes, sir.
This, for me, I used as my marker during the exam of this is a contrast scan or not. There's other things you can use, but it's just really important to make sure you have some appreciation of what a post-contrast sequence is. But other than that, yeah, your answer was pristine, perfect, very good.
Okay, sir. Thank you.
But so exactly right. So these kind of tumors, especially, I think a lot of these were involved with Epstein-Barr virus. I think in Western countries they're associated with human papilloma virus. So diagnosing and biopsy is a very reasonable approach, or they can do nasendoscopy. Anything more to add to that, Hassan?
You do core biopsies of the nodes, and they also take a tissue sample from the suspected site, which you recognize quite well. You said there was asymmetry at the fossa of Rosenmuller. So every time you see you're suspecting a head and neck cancer, always look for asymmetry. It's the easiest way to find it. And in terms of follow-up imaging, the first thing we do is just do a CT thorax for staging. That's what we do. If when we stage oropharyngeal cancers, CT thorax is what's important. So you don't do the abdo-pelvis, you do a CT thorax. And you said the same thing about refer to ENT and then discussion at the head and neck MDM. So all of that was perfect. Very good. Very impressed.
Excellent. Candidates at candidate 4, thank you very much. That was actually the last case. I think we also run over for time. Sorry for delaying everyone. Very good quality. If you are the candidates today have been sort of tuning into my sessions, I thought your management plans were really good. Keep going. My only main key advice for all of you would be try to just really make sure you have a succinct, I say one line, let's just say statement, let's just say 3 of the bare minimum number of words you can choose just to get your overall diagnosis across. That will really help you and it'll stop you from falling into that trap of continuously talking, continuously finding something new. But overall, very well done, candidates. Thank you very much, everyone else, for joining us. I will stick around for a short period of time just to answer some of the questions on the screen. I'll just have a quick scroll through what kind of questions have been coming through. The last diagnosis here was nasopharyngeal, if it is the one, nasopharyngeal carcinoma with nodal metastases. I think everyone else is just asking really on what the previous diagnosis was. So I'll stick around anyway. Fourth thing. So someone's asking if this was a necrotic node. Actually, have a look. The only reason it's coming up as bright as the sun here, you'll undoubtedly get a degree of necrosis over here. But the typical necrosis cystic looking nodes, this isn't it, because the T2 would have shown you that information. Whereas the stir and the post contrast sequences is picking up the edema inside. So it's not necessarily necrotic, although there is probably necrosis inside. So I hope that makes sense. So how to cover the rare cases? Read. Someone somewhere in your hospital is a specialist in what they do. They will have a collection of the rarest cases on the planet. Ask them, plead with them, tell them to ask them to help you, and stick with them. But again, one of the key things, the only way you can improve yourself in the domain of anything in medicine is you have to read. You have to sort of cover these journals, RSNA articles, clinical radiology, wherever you is a source of information. Or if you find a teacher willing to teach you, stick to them like glue, because that's quite rare these days. Right. So I think that's it. Thank you so much again, everyone. Have a good evening, and until next time. Thank you so much, Dr. Hassan Rahman. I appreciate your attendance, and hopefully the next session will be from Dr. Rahman, and I'll be assisting him as well in the next one.
Okay. Thank you, guys. Bye-bye.
Thank you.
Thank you very much, Saqib, and thank you very much to Hassan for a brilliant session. I'm sure everybody gained a lot, and these are absolutely gold for the audience. And the feedback which I get is that this is what we needed. So thank you, Saqib. You have covered, abdomen and pelvis as well as the chest, and started with the chest. Today, head and neck, brain, of course. So these have been brilliant. And for the audience, Dr. Hassan has pledged a session I think it's a blur in my mind, but it's coming somewhere in November. So you will see more of him. He's working in a tertiary center as a head and neck as well as neuro radiologist. So keep tuned to see that session. Thank you, Saqib.
Thank you, Dr. Khan.